Well, welcome everybody. Thank you so much for joining us today. I'm Carrie Frank with Civic. We are excited to be discussing the Colorado out-of-network law, which protects patients from surprise bills today. I am going to go through our agenda really quickly. We will be talking about the out-of-network legislation, rules, and regulations. There are some updates to the law in light of the Federal No Surprises Act, which we'll share with you guys. We'll be talking a lot about how the all-payer claims database has been used to establish payment parameters and the stakeholder engagement process that we've used to refine that data methodology. We'll have plenty of time for questions and feedback from participants out there. And please just note, we are going to be recording this session, so we'll have all of this available for you after the fact on the civic.org website. And any questions that you have throughout the day today, please you do use the chat box. I will be monitoring those. And if it's something that I feel we should jump in and ask the presenters as they're presenting, I will do that, but we might save some of them for the end. So don't be surprised if we don't answer them right away. We have three great presenters with us today. We're very excited to have Jill Mullen from the Division of Insurance. She is their policy advisor and has been working very hard on all of this out-of-network bill stuff, the current and past one. Pete Sheehan with Civic, he's our Vice President of Client Solutions and State Initiatives and has been very involved with out-of-network bill from the very beginning. And then we also have Paul Timmerman with us, and he is our Manager of Reporting and Analytics. And Paul has been doing a lot of work since he joined Civic to get the new COVID-related out-of-network fee schedule in place. So he's going to share with you about the methodology that we have been working on. Our mission, just if you're new to Civic, we are a nonprofit, we're independent and objective, and our mission is to empower individuals, communities, and organizations through collaborative support services. And really everything that we do, we provide health information and support to advance the triple aim of better health, better care, and lower cost. And we serve a variety of stakeholders with all focus with the consumer in the middle. Clinicians, hospitals, employers, government, state agencies that you'll be hearing from today, researchers, health plans, and nonprofits, all again to improve the lives of Coloradans. So today we're going to be talking a lot about the Colorado all-payer claims database. If you're unfamiliar with it, it's been around for 10 years. We have our 10-year anniversary celebration that we're celebrating all year this year. We have payers from across the board, all the largest commercial health insurance payers, Medicaid, Medicare Advantage, and Medicare fee-for-service claims. It encompasses the majority of lives. We have over 5 million lives in the APCD, or over 44 payers, and we're closing in on 800 million claims. So we're very excited about. So very comprehensive database that we can then use to inform both public information and non-public. So our public information is all on civic.org. We have a multitude of public reports. The out-of-networks fee schedule is something that also is public and available on the DOI website. But the Civic website has shop for care tools and all sorts of other exciting information that you can use at your fingertips. And then we also provide non-public requests, data sets and reports to address specific innovative work that's going on with other change agents in the country and here in Colorado. So with that, I'm going to go ahead and turn it over to Jill. Jill, thank you so much for joining us today and telling us more about what you've been up to at DOI with this bill.
Great, thanks. So again, my name is Jill Mullen. I'm a policy advisor at the Colorado Division of Insurance. So I'm here today to discuss Colorado's out-of-network surprise billing law, and then just provide some updates on changes to our law based on the Federal No Surprises Act. So next slide. Okay, so first, just some background on Colorado's surprise billing law. So out-of-network medical bills or surprise bills occur when a person is billed for services received from a provider or facility that is not in their carrier's network. The surprise bill is usually the difference between the total bill for the claim and what the patient's insurance carrier paid towards that claim. So Colorado passed out-of-network billing protections in 2019 with House Bill 19-1174. The bill became effective January 1 of 2020 and protects consumers with DOI-regulated plans in 3 situations: when receiving emergency care from an out-of-network provider, when receiving emergency care from an out-of-network facility, and then when receiving non-emergency care at an in-network facility from an out-of-network provider. The bill has a couple other provisions we will discuss in the upcoming slides, but as an overview, it establishes payment rates that carriers must pay out-of-network providers. It requires carriers, providers, and facilities to develop and provide disclosures to consumers about receiving care from an out-of-network provider or facility. It creates an arbitration process for carriers and providers to use to settle out-of-network billing disputes. And it also requires carriers to report to the division on the use of out-of-network providers and facilities and the impact on premium affordability. We've completed and released a report with the out-of-network data submitted for the 2020 calendar year. The 2021 data will be released in a report that comes out on July 1. During the presentation, I will be sharing some of the data from the 2020 report just to kind of show what we're seeing related to out-of-network claims. Next slide, please. Okay, so first I wanted to give more information on the payment rates that were established in 1174. I realize this slide can be a little wordy, but I did want to go through the payment methodologies because I know Civic will discuss more about the challenges of using claims data to determine some of these payment amounts. So we can kind of go through these. But also, I'll mention in all payment situations, regardless of how the payment works out between the carrier and the provider, the patient is only required to pay their in-network cost sharing requirement for those out-of-network services. So the framework for when for carriers, when a covered person uses an out-of-network provider, the reimbursement rate must be the greater of 110% of the carrier's median in-network rate for that service in the same geographic area, or the 60th percentile of the in-network rate for the same service in the same geographic area for the prior year based on claims data from the APCD. Civic might talk about this too, but the APCD rates are updated annually and posted on the DOI website as a reference. Or it can be a separate, negotiated independent reimbursement rate. There's a somewhat similar payment framework for when a covered person receives emergency care from an out-of-network facility. The reimbursement rate must be the greater of 105% of the carrier's median in-network rate for that service provided in a similar facility in the same geographic area, or the median in-network rate for the same service provided in a similar facility in the same geographic area for the prior year based on claims data from the APCD, or a separate negotiated reimbursement rate. The law also includes a separate reimbursement rate for emergency services received at an out-of-network facility operated by Denver Health. That is very specific to Denver Health, so I won't go into it today, but just wanted to mention that that is also in the law. So based on the data that we received from carriers regarding claims by out-of-network providers in 2020, across all carriers, the rate calculated based on 110% of a carrier's median in-network rate was the most commonly utilized payment methodology. But across all carriers, all 3 payment methods were utilized for out-of-network providers. For facility out-of-network claims, the rate calculated based on 105% of a carrier's median in-network rate was the most commonly utilized payment method. But again, across all carriers, all 3 payment methods were utilized. Next slide, please. Oh, okay. So I think I mentioned earlier that House Bill 19-1174 sets up an arbitration process to settle billing disputes between providers and carriers. The arbitration process does not involve the consumer. This is only to settle disputes between providers and carriers. So arbitration may be requested if a provider believes that a payment made was not sufficient given the complexity and circumstances of the service provided. The provider has 90 days after receipt of payment to initiate arbitration. Next steps in the arbitration process include the out-of-network provider may arrange an informal settlement teleconference to resolve the issue, but it's not required. We have noticed in most cases, we have seen attempts at an informal settlement from both parties. But if that doesn't work, once an arbiter is assigned, the parties have 30 days to submit their final offers. This is baseball style arbitration. The arbiter picks one of the two offers and the losing party pays the arbitration fees. For 2020, the division received 26 requests for arbitration. All requests were settled outside of the arbitration process. In 2021, the division received 570 arbitration requests. Of those requests, 280 went to arbitration. The decisions in those arbitrations were pretty evenly split in favor of the provider or carrier. I'll also note that Colorado is one of only a few states to pass surprise billing legislation that includes both a standard reimbursement methodology for carriers and a dispute resolution process for providers. One last thing I'll sort of mention related to 1174 is the data the division collected from carriers related to the impact of the balance billing protections on carrier networks and premiums. For the first year of data reporting, we had really limited information available regarding the impact on premiums. Several carriers reported that they were unable to draw any conclusions regarding premium impacts with only 1 year of data. Carriers also submitted information on the impact of 1174 or the impact 1174 had on networks. Most carriers reported no change in their networks. 2 carriers actually reported an overall increase in their networks in 2020, including an increase in contracting interest from certain practice groups. So the division will really work on refining this data and will hopefully have more to share in the future related to the impacts on premiums and carrier networks. Okay, that's everything on 1174. So I was now going to discuss how this sort of ties in with the Federal No Surprises Act. Looks like we're already on slide 5. Great. So in December of 2020, Congress passed the Federal No Surprises Act. The federal law became effective on January 1 of 2022, and this protects consumers from surprise medical bills when receiving emergency care at an out-of-network facility or from an out-of-network provider, when receiving emergency air ambulance transportation, but not ground ambulance services. And then finally, when receiving elective non-emergency care at an in-network facility, but treatment is done by an out-of-network provider. So actually pretty similar to what we had in Colorado, except Colorado didn't touch air ambulance transportation. The NSA really expands surprise billing protections, particularly because those protections now apply to self-funded plans. Another interesting aspect of the NSA is states can impose requirements on providers and facilities that are actually more protective for consumers, but the NSA really needs to serve as a floor of consumer protection. In terms of enforcement of the NSA, states will continue to be the primary enforcers with backup enforcement by the federal government if a state fails to substantially enforce the law. The Federal Department of Labor will continue to regulate self-funded plans. According to the Commonwealth Fund, about 18 states have passed comprehensive laws prohibiting out-of-network billing, and there's another 15 that have more limited protections. So there are likely several states that are looking into how to align with the NSA right now. Colorado being one of those states. Soon after the NSA passed, the division realized we would have to make changes to our state law to address inconsistencies between the federal and state law, but also to maintain some of the strong consumer protections in the NSA and ensure the division could enforce those protections against insurers. Next slide, please. Okay, so that brings us to House Bill 22-1284. This bill was introduced in the Colorado legislature in February. The division is working with the majority leader in the Colorado House, Rep. Esgar, and Rep. Catlin. I'll highlight a couple of key areas where we wanted to ensure alignment with the NSA, and all of these are included in 1284. So first, we're adding balanced billing protections for post-stabilization services. So this protection will ensure that patients are protected from surprise bills until they can consent to be safely transferred to an in-network facility after receiving emergency services. So protections for post-stabilization care were not included in Colorado's original balanced billing law. So we really wanted to adopt those additional protections from the NSA. We're also aligning with the NSA disclosure requirements for providers, facilities, and carriers. I mentioned earlier that 1174 included disclosure requirements for patients being treated by an out-of-network provider, but we sought to avoid providers and facilities from sending two notices to consumers, one to comply with the state law and one to comply with the federal law, as that only really creates more consumer confusion. And for the most part, the disclosures were really similar. So in 1284, we adopt the disclosure requirements in the NSA. We're also aligning with the NSA's notice and consent timelines. The NSA requires a provider or facility to provide written notice that the provider is out of network at least 72 hours in advance of the scheduled service, or at least 3 hours in advance if the appointment is made within less than 72 hours. It also has a requirement, the notice must include a good faith estimate of the amount of charges the person may be responsible for if they choose to use the out-of-network provider. And if the person is at an in-network facility, they have to provide a list of participating providers at the facility who can provide the same services, but would be in-network. So this is, Colorado law didn't really specify timelines for notice and consent, and it didn't really require this upfront estimate of costs. So both are protections that we really wanted to add to our statute. We're also aligning with the NSA and creating an exception to the notice and consent requirements for certain ancillary services. So this prohibits certain provider types from ever balance billing a patient regardless of consent. The list of these providers primarily includes provider types that patients have no control over receiving services from, like anesthesiologists, assistant surgeons, radiologists. So Colorado's law didn't actually prohibit provider types from ever balance billing. So again, we wanted to align with the NSA on that because it was more consumer protective. And then finally, we are updating statute to allow for a 90-day period of continued coverage at in-network cost sharing for transitional care. This will require carriers to continue to cover an individual's care at the in-network rate for 90 days under certain circumstances. Colorado law currently only allows for 60 days of continued care, so we expanded that time frame. So the main goal of this bill is really alignment and to alleviate the potential for confusion for all entities, with the NSA and our current state law, being effective at the same time. And I do think that we have struck a good balance with this legislation. Next slide, please. So next steps. House Bill 22-1284 is still moving through the legislature. The bill passed out of the House Health and Insurance Committee last week, and it actually passed out of House Appropriations Committee this morning. Both committees, it passed unanimously. We expect it to be heard on the House floor sometime soon. And we've really been working with all interested parties to ensure agreement and alignment on this bill. Other next steps include changes needed based on upcoming federal rulemaking. We are anticipating rules on the good faith estimate. We specifically included language in 1284 stating that the requirement around providing a good faith estimate will not be implemented until federal rules are implemented. So the division will need to issue rules or potentially update existing rules based on those federal rules as they come out. And finally, we're really reviewing our own existing rules to determine what we may need to update to align with the federal NSA. Next slide, please. Yeah, we can do questions now or at the end if anybody has questions.
Thank you, Jill. Excellent information. I learned a lot. I appreciate that. We are so grateful that you're here today. I don't see any questions right now, but just a reminder for folks on the phone, if you do have questions for any of our panelists today, please use that chat button and we can definitely take those either as we go or save them for the end. We'll have a formal Q&A at the end as well. So it doesn't look like we have any right now. Oh, one question from Carol. Go ahead, please. If you don't mind typing it for us. Unless we're able to open her line. I don't know if we can do that. Carol, if you don't mind typing it, I think that's our easiest option. So while she's preparing that, oh, here it comes. I think she's saying it's the document that patients get and receive, or the literacy level is pretty difficult, and she's a surgeon and didn't understand it after being a patient. So I think that that's definitely a concern. So is there anything, Jill, that you guys have in the legislation that says anything about health literacy levels, that it should be something patients can understand? Because that is a great point.
Yeah, I actually think the NSA has a requirement that the disclosures have to be in plain language. But I would also add the Centers for Medicare and Medicaid Services, CMS, has model disclosures on their website that providers can use. And I don't know what the uptick has been on using those, but I do feel like CMS has provided a lot of guidance in this area to use, the forms that they have on their website. I think that's what I would say. We have language in 1284 that also sort of says, the disclosures have to be in plain language, because I agree, it is really important that they get these disclosures, but also that like consumers can understand them and understand what they're consenting to.
Mm-hmm. Yeah, I think that's a great point. And I think it's nice that there is language out there already. That seems silly that everyone would be creating their own. And if there's something that has been tested that is understandable for folks, that would be something that would be helpful. Okay, thank you, Carol, for that. I am going to now turn it over to Pete to talk a little bit more about the APCD role. And thanks again, Jill, for being here in that great presentation. And Jill's going to stay on the line, so if we have more questions for her later, we can address that. So take it away, Pete.
Thanks, Carrie. In my portion of this, I'm just going to talk a little bit about how did Civic become involved in this, and then the data source of the Colorado APCD before Paul gets into the methodology of how things have progressed. Jill touched on the first two bullets on this slide, but the bottom two, just wanted to touch on briefly. Within the legislation, we were named as a source to help establish the amounts that the out-of-network providers can bill and get paid by the payers in Colorado. What we do at Civic is use data from the Colorado APCD to calculate a data set or fee schedule for each of the 9 Division of Insurance rate setting regions within the state. For those of you in Colorado, you understand the rural Front Range and Eastern Plains geography of the state. For those not here in Colorado, the terrain is pretty varied, and the population centers and the amounts of claims in each are also varied. And so it's important that we do align with the Division of Insurance when creating these, because that's how the rates are set within the state. Let's go to the next slide. This has gotten a lot of attention in Colorado. Even prior to the 2019 session, there were a few attempts to address the surprise billing issues that failed. It's a complex issue. You've got various points from both perspectives on the provider and the payer side that are valid. And it really did take a lot of work from all those different stakeholders to come together and find a common ground. There were major stakeholder groups involved in discussions prior to the 2019 session. As part of those discussions, one of the things that came to light was the need for objective data to help inform those discussions. And we provided an objective view into some of the ways you can slice and dice the data, and were deemed independent so that our data wasn't weighing or providing an advantage to any of the different sides of the stakeholders that were involved in the discussions. So just a quick list of those who are involved here in Colorado: the governor's office, obviously the Division of Insurance, the Colorado Consumer Health Initiative. They really represented the consumer view and the patient view of this, and were very instrumental in terms of the discussions. The Colorado Association of Health Plans, the Colorado Medical Society, the anesthesiologists, the emergency medical services groups, and many, many more. Too numerous to mention here, but I will tell you the first stakeholder meeting that I was involved in on this at the beginning of the 2019 session was the largest stakeholder meeting I've ever actually been involved in. Many, many different groups, many, many different people all coming together to try to solve for this. As part of the conversation unfolded, those stakeholder groups, primarily the bigger ones, the Colorado Association of Health Plans and the Medical Society, as well as the state, were interested in taking views of the data that we had access to help understand and inform the different positions that they had with regard to the legislation. They reached out to us. We did provide data to support those requests. And it was interesting. Each group had a slightly different perspective, and the requests that came to us wanted to see the data sliced slightly differently. Sometimes it was around the inclusion of the services that were requested. Sometimes it was around different percentages of in-network rates that had been billed the previous year. And we were able to address those requests. And I think those requests helped then inform the legislative discussion as it played out at the Colorado General Assembly. Those percentages change frequently in the negotiations. So some committee hearings, we were talking about 60 to 75%, sometimes as low as 50%. And those targets changed as those discussions unfolded, and the state kept coming back to us, as well as the different stakeholder groups requesting data sliced out at different percentages. We tried to accommodate all those requests, but as those of you who are familiar with legislative sessions, these things unfold quickly, and it's really a challenge to respond to everything in a timely manner. But we did our best, and I believe the data did inform those discussions. Paul Timmerman is now going to talk to the group regarding the methodology that was chosen and walk through some of the challenges involved in determining the methodology.
Thank you, Pete. My team is I have a team of analysts that did the work last year and this year for these fee schedules. So I'm going to talk a lot about that right now, talk about the methodology. The data we determined to push out had two different fee schedules. One was professional services with the 60th percentile amounts and emergency services at 50th percentile amounts. These are the standard schedules that we created in the first year and also this most current year. And the data is reported annually with the most recent calendar year available of data. As most people know, claims data does have a lag. So we try to get the most current and complete data to use for the set, and it's delivered in December. And a lot of the fee schedules are going to talk about allowed amounts, and there's a definition there that talks about this is the combined amount that the payer and the patient pays for services based upon claims in the Colorado APCD. And it's been mentioned a couple times about the DOI regions, but here's a good map and some good information on that. There'll be some fee schedule examples later, which will show these different regions, but there's 9 distinct regions, and there's also a 30 claims threshold per DOI region or at the statewide level. So there's some volume considerations to this, which will be touched upon in a future slide. Not this slide, however, but our data hurdle number one was volume. In order to determine a stable rate of reimbursement, it requires sufficient volume. And there's some language in the bill. If the volume of services fall below a threshold in a DOI region, the in-network Colorado APCD allowed amount is used. If statewide volume falls below the threshold, the fee is based upon the payer median as the only source that we have. And if the payer does not have an in-network rate, then it goes to arbitration, which I think Jill touched upon earlier. So our team was left with the essential question: what should the volume threshold be? And the next slide should probably go into a little bit more detail on that. This is the exercise that our team went through to try to establish the volume threshold, and basically just trying to do the, evaluate the interquartile range. And, this graph is not, it might be clear to others more than me, but it basically, we settled on the recommended volume of threshold being 30 claims. Another hurdle was anesthesia claims. As most people know, anesthesia claims are not simple. The payment's based upon many factors, CPT codes, the provider and provider role, the patient physical status, and time units. The anesthesia claims submitted to the Colorado APCD had some problems. The volume can be small for some of the combinations of code and modifier, and some of the time units are reported using different definitions by some of the submitters. Sometimes it's actual minutes versus 15-minute increments. And then some payers hard-coded the time unit values as 1. So these are significant quality issues we had to work through. And the solution that we ended up coming up with was we adopted a method used by the state of Oregon, which is based upon a calculated regional conversion factor, and came up with conversion factors in the dollar value when combined with the CPT code and units and modifiers in order to calculate a payment amount. It establishes a mechanism for the payers to use for the CPT codes and modifier combinations. And it uses an aggregate of all the clean data we had to report the conversion factors. So it made low volumes less of a problem. And we have worked closely with payers to try to fix these qualities with units over time, and we expect that to continue in the future. And here's a chart that shows how you can use the information that's actually on the DOI website to calculate anesthesia fees. There you select your code, the modifiers, the time units, exclude data for payers that report only time unit of values. You calculate the 60th percentile amount, report it, and then calculate it, and then I think your work is done. But it's just a simple illustration of what needs to be done with the data that's provided in the fee schedule. Hurdle number 3 for data, just emergency facility services. A significant percentage of the in-network services report with a $0 allowed amount. Some of this is due to bundling, some of that are in some of the payer contracts for emergency services and evaluation services. And emergency services can encompass a variety of hospital services depending on the patient's condition and healthcare needs. And I think the next slide kind of illustrates that. As everybody knows, not necessarily everybody knows, but emergency department can lead to an observation stay, an outpatient, or an inpatient admission to a hospital. So there's many complicating factors there. And calculated case rates for most emergency services was a factor as well. So the fee schedules we ended up with that are actually published have emergency room services for case rate by evaluation and management codes, excluding high-cost services, has carve-outs for high-cost drugs, implants, advanced imaging, nuclear medicine, cardiac cath, and trauma activation. There's a separate fee schedule for observation case rates, outpatient OR case rates, and then admissions from the ED, which are reported by MSDRG codes. Admission from the out-of-network ED, the allowed amount for admissions following a visit to an out-of-network ED is defined by MSDRG. Some of the challenges is that the bill itself only addresses only services before stabilization. Another challenge was there was no mechanism to separate the ED services from inpatient services acceptable to providers and payers when the patient is stabilized and transferred to an in-network facility. And then there was also some low volumes for many of the MSDRG codes. The potential solution is attempt to split the bills for ED and inpatient services before transfer to the in-network hospital. Data hurdle number 4 is ambulance services. They typically have low volume. They're public and private services, and there's lots of diversity among the service providers and financials. So bottom line is Colorado APCD is not used for ambulance services. There's not a fee schedule out there for that, but there, I have been told there is a DOI developed payment formula based upon Medicare rates. A new curveball happened in 2021 when we were working on this fee schedule. We had to address COVID, and it was determined we had to create a separate fee schedule in light of the pandemic. And the primary reason was that the related COVID-19 related fees were covered under the emergency order during the time period of the pandemic. COVID related services reported at 50th percentile only. And the time period we used for this fee schedule was January 20 through June of 21 to attain at least 12 months of complete data during the time. This was unique to the COVID schedule and does not apply to the standard fee schedules. So we made a little stretch in order to get the most data we could. A little bit more on the COVID methodology. After we collected sufficient runout of the claims data in the APCD, it was determined that we needed to split the fee schedules. We wanted to do it between testing and treatment. The testing we split between professional, it captures tests that are billed on a professional claim, and then facility, which is any COVID test billed on a non-emergent facility claims. The treatment split was split between outpatient and inpatient. Outpatient focused on non-emergent outpatient facility, and inpatient focused on MSDRG codes billed with that diagnosis code you see there, U0571. And same with that same diagnosis code is important in the first one too. Oh, and is that the next one? Yeah, we're done with COVID. Okay. Gaps in delivering the fee schedules. Just that there is low volume might result in some codes not being on there, invalid data from submitters. Sometimes there's unusual results from one particular payer that influence the number. And there's no standard method of defining services for established fee schedules. And there's some limitations on the legislation as well. Lessons learned. If anybody's wanting to take on a project like this, we suggest you engage with the stakeholders as early as possible and get on their calendars and talk to them about it, establish a mechanism to communicate, and then work with payers or submitters to fix invalid data, like the unit values we saw for anesthesia services. And then potential updates in the future, this will be spoken about, the additional fee schedule, reference when Colorado APC volumes are too low, and then possible solution to the problem of post-stabilization for payments emitted from the ED. Now I'm going to show you some results. Here's an example of a professional fee schedule for CPT code 99213, which is a E&M code for an established patient office visit. And you can see some of the rates there by DOI region. You can see there's there's some variation in some of the DOI regions rates there. So as you remember that chart we showed of the 9 regions, you can see the example of a fee here for that code. For example, number 2, CPT code 43239. I'm not going to try to pronounce that. It's an esophagus surgery, is how I would say it. And you can see the rate there reported at 50th percentile. The rate is the same among all DOI regions. So this is an example where the rate ended up being the same. And then from our COVID methodology, the code there, infectious disease with the pathogen specific to SARS-CoV-2 testing. You can see the rate there at the 50th percentile amount. Some variation in a couple of the regions, but the rate seems consistent among several of the regions there. And then COVID results for MSDRG codes for inpatient treatment. And this is for DRG code 177 for respiratory infections with major complication or comorbidity. You can see the payment rate there is comparable in some regions, but there's some wide variation in the DOI regions. Yeah, I believe that's the end of my part. It either goes to Carrie or to Pete at this point. Thank you, everybody.
Thank you so much, Paul. One quick note. I wanted to go back to the one that was the same. And I think just to clarify, I think with this one, if I'm not mistaken, the 1 means that we had to use the statewide because there wasn't enough volume. So the reason that it's the same is that that's actually the statewide, because at the individual DOI level, we didn't have enough volume. So anytime you see the 0 here, we're actually using that particular DOI region, whereas the 1 indicates that's the statewide average.
Okay.
So just wanted to clarify that. But yes, I think Pete, you're gonna take on this one.
Yeah, thanks, Carrie, and thanks, Paul, for the comprehensive review of the methodology. There's a question from Indiana regarding a link to the data sets. Stephanie provided that link in the chat box to the Colorado Division of Insurance website that has all the information related to the legislative and regulatory requirements, as well as access to the data sets. Over the course of the past year, provider groups have expressed an interest in further transparency. And so that resulted in some conversations leading to Senate Bill 2268 by Senator Rodriguez, which is going through the legislative process currently. The goal here is to provide stakeholders with views into the in-network payments for CPT HCPCS codes that goes beyond just the 50th and 60th percentiles that are included in the out-of-network data sets. If everything passes through the legislature, CIVHC will be required to produce a tool to provide a view into this information online. And then the first release would be scheduled for January of 2023 and include data from 2018 through the most current year of data available. Let's go to the next slide. So here we just have an example of what we envision the tool looking like. It's a mock-up of what's been produced and is an example only. But as you can see, I'm just going to try to find a code I'm familiar with. Let's take about halfway down. There's 99213 office outpatient visit, about $97 all the way across. But you can see there's average cost that gets in the 25th, 50th, and 75th percentile. Let's go up one. Let's see, the top one is also the same across the board. I'm looking for one that's differentiated across. Well, these may be mock numbers. So anyway.
They're all fake numbers. So
Okay.
you can find one that has a lot of difference. It's copied and pasted.
There you go. But the goal is to not only outside of the 50th and 60th percentiles, go to kind of the outliers and show the range of payments down to the 25th percentile and up to the 75th percentile too, and it'll be a searchable tool. As you can see across the top, you can pick specialties, payer types, place of service, inpatient, outpatient, and the year, then the county and the DOI region.
Okay. Yeah, and just again, to clarify, we have to, or not to clarify, but to reiterate, we are, if this bill goes passes and it's, I believe, in appropriations, or if it hasn't already gone through appropriations, we will have to provide this, and it'll be on our website, this tool, in an interactive manner in January of 2023. And we, by the law, have to go back to 2018. So at that point in time, we should have data available through at least 2021. I know this mock-up says 18, 19, 20, but we'll have as many years as possible going back to 2018 per the law. So thank you. Any questions? We've covered a lot of ground. We would love questions or feedback or anything from the audience. If anybody, I know we shared the DOI site. Thank you, Steph, for doing that. All of this will be on our website, on our events tab, the slides, the recording, links to the recording, and all of you should receive that in a follow-up as well. But we would love, if any questions come up after the fact, please reach out to us at info@civic.org. And we would be happy to share more. Let's see, I think we have. Thank you, Jonathan. We appreciate you being here. No questions, but just saying this was a great presentation. We appreciate that. Thanks for joining. Oh, here's a question from Sharon. How do you define whether an MSDRG was in network? Paul or Pete, want to take that, or you want me to? We have flags in the APCD data that says the payers actually submit claims and say what they indicate, whether it's an in-network claim or an out-of-network claim. So we're using the flag that the payers submit, I believe. If I'm wrong, let me know that.
You're correct. Just to add to that for the group, those flags are really important. And at the beginning of the process, there was a high percentage of claims that were coming through. It's either a yes, no, or a U for undetermined. A high percentage of those were U. As this process progressed, we did a lot of outreach with the payers to ensure that they were capturing that information and reporting to us correctly. And over the course of a year, that's actually probably shorter than that, 6 months to a year, the percentage of use went dramatically down. And we are very, very confident in our flags in the related data at this point in time. And that's a great testament to working with all the different stakeholder groups and everyone understanding that this data is really important and we all have to have confidence in it being accurate.
A follow-up question from Sharon. I think the question is around, do we have a sense of if it's on one DRG, if there were some in-network providers and some out-of-network, does the claim specify that level of detail within one DRG? I don't know the answer to that question.
I don't know it either off the top of my head.
I do not either. Apologize.
We might have to get back to you on that, Sharon. Thank you. All right. Any other questions? Feel free to chat them in. Otherwise, we can give you guys 11 minutes of your day back, which I'm sure everyone would enjoy. I know everybody's busy and we appreciate you guys being here. And special thanks so much to Pete, Paul, and Jill. Thanks for joining and presenting today and sharing all of this great information. Again, all of this will be online on our website and you'll get a follow-up email. And we'd love for you to fill out the survey too after the end of our event today to let us know other topics that you might want to hear on our monthly webinars and any other feedback you'd like to provide. We will be sharing our upcoming webinars. We don't have them solidified for May, but we're working on some great stuff for May and June. So stay tuned. You'll be seeing emails with registration information shortly. So thanks again, everybody, and have a great rest of your afternoon. Take care.